friends, greetings and welcome. It's really nice to have you all here. And all of you know, this is our first Oral Pathology 360 Masterclass along with Vishnu Dental College, who's organizing this with us. And it is really great to have Dr. David here. You know, most of us have watched, who have been on LinkedIn, we have been watching his work through the years. He keeps sharing these little snippets about his lectures, about his pictures, and the way he develops the curriculum, tempting all of us, making us feel very envious that we can't attend it. And well, finally, we have him here. So we can attend it, we can watch it, and it's great. And as a little side note, I have to tell everyone who is interested in teaching or who's a teacher that besides the content, of course, the histopathology, which is great, but you should also pay attention, I think, to the way he presents it, because I think he is a master teacher too at the teaching itself, besides the content. So this will be a very, two things that you will get side by side. And with that, let me just say welcome, Dr. David. I will also welcome Ravikant. Dr. Ravikant Maniam is representing Vishnu Dental College. He is the professor and head of the Department of Oral Pathology there. Let me not take more time. Ravikant, I will let you do the introduction.
Yes, ma'am. Thank you. It gives me an immense pleasure to welcome Dr. David Klingman to the Masterclass program, An Immersion in Head and Neck Histopathology. I take this opportunity to introduce Dr. David Klingman. Sir is a graduate of University of Medicine and Dentistry, New Jersey Dental School, and he has completed a hospital-based general practice residency, an additional year of oral medicine training, and also a 2-year advanced education in general dentistry, and also a residency in oral and maxillofacial pathology. Dr. Klingman is a diplomate of the American Board of Oral and Maxillofacial Pathology. He is also a diplomate of the American Board of General Dentistry. He holds a faculty appointment as associate professor at Uniformed Services University. He is a well-renowned instructor in oral pathology, oral medicine, and radiographic interpretations, and teaching more than 350 plus residents every year with 100 plus hours each year. He's also an Air Force Surgeon General Consultant in oral and maxillofacial pathology. I take this opportunity to welcome Sir to begin his the talk on the oral histopathology and the masterclass program, which everyone is waiting for. Dr. David?
Yes, awesome. Awesome. Well, thank you, everybody. And it's nice to be international. It's like I'm visiting India without having to leave my own home. So I want to give a little history about this. This originally was intended as a study review for the individuals taking their boards in oral maxillofacial pathology. There's so much to know in head and neck pathology that it causes stress, right? How do you know everything there is? So this is my effort to distill or condense everything that I've learned over about almost 15 years, if you count my residency program, to try to help everyone tease out what it is that I need to do to make a diagnosis. So I will start with my disclosures. I have none. If I show you any kind of products, I'm not endorsing them, and I have no financial disclosures. So the way I approach things is we talk about lumpers and splitters, right? We put all these things, there's so many lesions out there, and they keep adding diagnoses. So what I've tried to do is distill these into broad categories. So we're not going to spend a lot of time talking about oral medicine today, but this becomes part of our thing. So when I'm teaching oral medicine, I'm usually trying to teach categories of diseases for my learners. So I've listed here sort of the major sort of oral medicine areas. So we tend to think of oral medicine as pathologists and oral medicine practitioners as, okay, what is the autoimmune disease? What is the dermatologic disease? So when we're looking at oral ulcerative diseases, are they simply traumatic or aphthous ulcers, or are they indications of something systemic? Then we have the whole lichen planus, pemphigus, pemphigoid subculture of dermatologic diseases in the oral cavity. So we start with those. Then we have the oddities, right? The chronic ulcerative stomatitis, the epidermolysis bullosa, the erythema multiformis, the graft versus host disease, and then things like geographic tongue and psoriasiform mucositis. And then we have sort of all the foreign invaders, so to speak, of oral medicine type things, right? What are the foreign materials that get into the body? Whether or not that's dental materials that will sometimes show up on our slides. Do we have viral infections, either the ones from the herpes viruses or the papilloma viruses? And then there's a few things like Kawasaki disease, or do we have oral pigmentary lesions? And sometimes those are simply metallic implantation from dental materials, or are we trying to exclude melanomas? And then we have sort of the systemic things that happen that present themselves in the oral cavity, right? So our medication-related osteonecrosis for our individuals that may have IV bisphosphonates or medications, or do they have a metabolic bone disease that shows up on a radiograph? Or do they have some sort of granulomatous disease that shows up as a vasculitis or a temporal arteritis? And then what's new, right? So there's all the salivary diagnostics and all these tools that we can use to try to tease out, is this a malignancy or pre-malignancy? The drivers, maybe we need to biopsy. Then there are the whole sort of syndrome cases. So when I think of syndromes, I try to put them into broad categories. Is it something that's going to be associated with bone, so all the opalescent dentin, or is it something like amelogenesis imperfecta that's associated with ectodermal defects? Then there's all of sort of the facial dysmorphism cases. There's the collagen defects, and then there's things that show up in the oral cavity that are the result of either the oral cavity being the beginning of the gastrointestinal tract, so Crohn's disease, and then there's also some diseases like adenomatous polyposis, sort of the premalignant GI polyps that show up strangely as osteomas and odontomas. And then there are a number of genetic diseases that are presenting themselves in the face of the oral cavity as a result of whatever the genetic defect is. So, we talk about the vascular malformations and things like Sturge-Weber syndrome. We talk about Peutz-Jeghers manifesting as freckling around the mouth with benign GI polyps. Then we have a whole series of endocrine disorders that for some reason show up in the oral cavity as neuromas and neurofibromas. And then we have genetic diseases that show up as cysts in the jaws. And then we have the concept of, do the patients have Nevi basal cell carcinoma syndrome? And then we started getting into the actual pathology. So skin pathology is certainly not my area of expertise, but we see a lot of dermatopathology as oral pathologists. So I try to characterize these things into one of 5 major categories. Are they from the follicular complex, from the glands, or are they truly malignancies like squamous cell carcinomas, basal cell carcinomas, melanomas, Merkel cell carcinomas? And then there's a subset of these that will manifest with sort of odd oral diseases. So things like eccrine tumors, like cylindromas, can show up with salivary tumors. And then there's all the soft tissue tumors that we have to sort of deal with, and they do show up in the oral cavity. So there's everything from the relatively benign things like granular cell tumors and some sort of developmental abnormalities like osseous chorostomas. Then we start getting into truly soft tissue tumors, right? There's vascular tumors, and now we start picking up genetic disorders. And then we have a whole series of histiocytic disorders that include both Langerhans and non-Langerhans cell type histiocytoses. Then we have the whole lipoma versus liposarcoma description. And then we have all the nerve tumors that I mentioned before, some of them like neuromas and neurofibromas that might be associated with genetic disorders like neurofibromatosis or endocrine neoplasias. And then we have a subset of those that are starting to turn out to actually have genetic characteristics. So I've listed them here. Then there's melanocytic lesions that you can view as soft tissue tumors, right? And the challenge is to figure out, is this benign or is this malignant? Then we have all the SRBCTs, right? The small round blue cell tumors that oftentimes will show up in the sinonasal complex. And our job is to tease out either genetically or through immunohistochemistry. And we'll try to talk about that a little. Which tumor is it? Because it matters more and more for not just diagnosis, but for therapy. Then there's all the myofibroblastic tumors. So our job is to figure out, are those reactive or are they the first sign of some low-grade fibromyxoid tumor? And then you add additional genetics to it. And then we have all the myxoid tumors. Some of those also turn out to be malignant and have genetic things. So there's extraskeletal myxoid chondrosarcomas as an example. And then you have all the muscle tumors and the parasitic tumors, and there's genetic markers we can use for those. Then there are picomas. I don't see very many of them, but we know they exist. Then there's benign skeletal muscle tumors. And then there are, at the right, malignant skeletal muscle tumors and malignant soft tissue sarcomas, many of which now seem to have a genetic component to them. And because the thyroid is in the head and neck, I'm going to show you some thyroid cases and show you what I've learned about them. And then you have salivary tumors. And this is probably one of the areas we've probably learned the most about it in the last 10 years. So when you look at individuals like Raja Sitala, who have been working on the genetics of this, right? The World Health Organization keeps updating this. And then we know there's all sorts of ancillary tests we can use for this, including FNA, immunohistochemistry, molecular testing, and even some immunohistochemistry to tease out, are there like immune disorders related to those? Then we have all the necrotizing salmonoplasmas. And then we get into the actual tumors, right? Are they benign tumors like monomorphic adenomas, canalicular adenomas? Are they these biphasic tumors that maybe have a myoepithelial and an epithelial component? Are they oncocytic tumors? Are they combinations of oncocytic tumors with lymphoid things, so Warthin tumors? Then there's a whole series of ductal papillomas. Then there are truly myoepithelial tumors. Then we get into the basaloid tumors, including myeloblastomas. And then we get into some of the newly described things or the newly described genetics. So we have those cribriform adenocarcinomas of the tongue and minor salivary glands. We have another set of biphasic tumors that have an epithelial and a myoepithelial component. So adenoid cystic and epithelial myoepithelial carcinomas, EMCAs. Then we get into these sort of, quote, low-grade tumors that all sort of overlap. So our polymorphous carcinomas, our mucoepidermoid carcinomas, and then there's all the clear cell things that start happening. Then there's the confusion between acinic cell carcinomas and secretory carcinomas and other low-grade cancers. Then there are some cystic adenosis cases, salivary duct carcinomas. Now we start getting into high-grade tumors. And even some of these will present themselves in the sinonasal complex as adenocarcinomas that bear similarity to the oral ones. And then we're in the sinonasal complex. Then you truly have a subset of sinonasal tumors, including adenocarcinomas similar to those we see in the oral cavity. Then there's all the polyps, papillomas, and hamartomas, which oftentimes will collide. And you'll see features of many of those. And then it's a site for unique presentations of soft tissue tumors that may histologically look like other tumors, like so-called glomerulopericytomas, GPCs, versus their soft tissue counterparts, hemangioparasitomas or those tumors. And there's actually different genetics to them, and there's actually maybe different behaviors to those. And then there's this whole series of fairly newly described genetically driven tumors, INI1 deficient tumors, nut carcinomas, and then there's even tumors that bear similarity to thyroid type carcinomas. And then you also have the really strange tumors in the sinonasal complex. So you have all those small round blue cell tumors. You always have a propensity for metastases or extension from other areas like the brain or the chordoma type tumors, or from things from the middle ear, or extensions from the brain, the pituitary gland, or if you have a maxillary odontogenic keratocyst, that could extend its way into the sinonasal complex if it works its way into the sinus. And then there's eye tumors that can grow. I have a friend who has just had his eye removed because of a squamous cell carcinoma. There's a whole series of infectious diseases, fungal diseases, things that happen in there that we have to tease out. And then there's the kind of the areas that we all like. These are kind of my favorite tumors, right? The odontogenic stuff. This is from where my training comes, right? I'm a dentist. Like a lot of us are in the dental field. So we see all these tumors that are either mesenchymal or epithelial or combinations, and some of them have mixed characteristics with odontomas in them. And then you get these calcifying tumors like Pinborg tumors. Some of them we're finding out have molecular and genetic changes to them. And then you actually have all these variations of ameloblastoma. Some of them look like carcinomas. Squamous odontogenic tumors will look like cancer to an untrained eye. And then you have all these sort of cystic areas. So all the things like orthokeratinizing cysts, odontogenic keratocysts, dentigerous cysts, glandular odontogenic cysts. And then you have some soft tissue type tumors of sort of the pulpal complex. So your fibromas and fibromyxomas. And then you're in the jaws, so you're in hard tissues. So there can be cartilage producing tumors, bone producing tumors, fibroosseous lesions, combinations of fibroosseous lesions with metabolic type diseases that include fibrous dysplasias as part of a syndrome, giant cell lesions that may be part of hyperparathyroidism. Then there's all kinds of foreign materials and changes secondary to metabolic diseases. So there are pyrophosphate deposition diseases. There are osteonecroses due to the medications. You do see some small round blue cell tumors, some metastases, cancers like prostate and breast will go to the mandible and the maxilla. And then the area I think that we're probably the least comfortable with will be all the lymphoproliferative diseases, right? All the lymphomas and leukemias. And this is probably one of the most rapidly changing areas as well. And oftentimes it's in our best interest to seek assistance from our hematopathologists, because there's a lot of genetics behind this. There's a lot of immunohistochemistry behind this. There's flow cytometry, and that actually strongly affects the management of these individuals. And then I think we always need to be on the lookout. Sort of my last comment about this as I talk about the broad topics we deal with is, what are the new things that we find? So when we're studying for board examinations, or we're studying for specialty examinations, or we're trying to renew ourselves and we're going to meetings, this is the kind of things that tend to get talked about at meetings, right? What's new in soft tissue tumors? What's new in genetics? What's new in immunohistochemistry and molecular testing? So that's kind of my very long overview of all the things that we have to know, not just as oral pathologists, but we also have to potentially be like any other pathologist, a soft tissue pathologist, an endocrine pathologist, a skin pathologist. So in that context, what I want to do is walk you through. We're going to do some groups of tumors here. And after each group of tumors, we can pause for a moment or two and see if there's any discussion. So I'm going to start with an area that I think that's fairly familiar to all of us. And we're going to start with salivary tumors. And my interest sort of has been in these sort of low-grade salivary tumors that overlap with each other, right? The mucoepidermoid carcinomas, the acinic cell carcinomas, the secretory carcinomas, the cribriform adenocarcinomas. Sometimes they have overlapping histologic characteristics, and our job is to hopefully figure out which one we have. So what we'll do is I try to start all these with sort of a 20x or a 100x view, and then we'll work my way up to about 200 or 400x. So what we have is, I can always ask the question of my learners, what gland is this? So if you look to the left, you'll see there's actually an admix of glandular tissue and some fat, and we'll find out that we're in the parotid gland. So this is largely a cystic tumor that sort of has this mucinous, inspissated material in the center with these cholesterol clefts. And I'm just working you around the tumor to see it actually is fairly well contained. We'll see some tumor growing into the lumen of this, and that's going to be our area of interest with our normal gland around the edge. So we'll work our way around to determine, okay, this is a fairly well encapsulated tumor for whatever it is. But when we start going a little bit higher power, we will start to see cystic areas that have some sort of secretion in the center. So we start thinking about, okay, what are our tumors that have some kind of secretory component? So actinic cell carcinomas, mucoepidermoid carcinomas, secretory carcinomas. And then we start looking high power. Now we can start teasing out the cytologic features of these. So what I know is I have cells that sort of look somewhat basophilic. So I can start saying, okay, maybe I'm leaning towards actinic cell carcinoma here because of the basaloid or the basophilic characteristic. Other areas are somewhat more solid, but when I look at the cells, they still have that sort of somewhat basophilic or amphiphilic cytoplasm. You'll see enlarged nucleoli. These are features of sort of malignancy when I see nuclear changes in nuclear features, but they do have this secretory component. It will start to remind you potentially of colloid, thyroid material, and that can be one of your clues to this tumor as well. So I've got a short differential now of actinic, mucoepidermoid, secretory carcinoma. All right, so I would, this is the point where I would open it up to my students to go, which way do you want to go with this? So what we actually determined on genetics in this case is this is a secretory carcinoma, right? It's not quite as purple as an actinic cell carcinoma, but it's still purple enough, but it has that sort of bubbly appearance. So how do you tease that out? We're going to figure out how does you determine what else can you do to make sure it's a secretory carcinoma. So that's the first sort of low-grade secretory type adenocarcinoma. The second is a salivary gland mass that's going to bear strong similarity to this case. Once again, I can ask my learners which gland. So I have gland admixed with a lot of adipose tissue. So I'll tell you we're in the parotid gland. And again, I have this very cystic kind of tumor that seems to be fairly well contained away from the inked margin. All the way around, it seems to be fairly well encased within this somewhat capsule all the way around. When I start looking higher power, now I'm seeing this tumor looks much more basophilic. It's less amphiphilic, more basophilic. And when I start looking at these, now I start to see these sort of secretory granules or these, these zymogen type granules. So now if I'm in the same differential diagnosis of actinic cell, secretory mucoepidermoid carcinoma, and I don't see as much secretory product, and I look even in the other areas, there's some optically clear cytoplasm, but I still have enough of this sort of granular basophilic cytoplasm. And then I have this surrounding lymphoid stroma, and that's very common of this tumor. So I would ask my learners at this point, what's your preferred diagnosis and how will you tease it out? And I have an actinic cell. So those are those two tumors that we've learned that, when we look at Elena Skolova's work, right, we know that these are tumors that have been teased out as sort of overlapping in their histologic characteristics, but we'll talk about the genetics of those. The third case I want to show you, and I'm going to show you cases in threes, because I watch a lot of Steve Jobs and all that stuff. So we know that the brain handles things in thirds. That's kind of how I teach. So the third mass we're going to see is that it looks kind of cystic, and it does have this sort of cystic, but now what I'm seeing is a different kind of cytoplasmic and nuclear characteristic. I'm seeing much more of a columnar type cell feature. I'm seeing much more of an oncocytic or an oxyphilic characteristic to it. And now I start seeing this pseudostratification, and it almost looks like respiratory epithelium. But the nuclear features are fairly innocuous. They're fairly bland. The nuclei are small compared to the cytoplasm. They seem to be respecting each other's borders. Even though there's a lot of infolding and papillary features of this, the nuclear features are still fairly innocuous. They're sort of uniformly, they're somewhat hyperchromatic, but they're all very small and fairly round and don't seem to be overlapping. and I would ask my learners at this point to tease out. And this one turned out to be a benign tumor. But you have these cystic kind of tumors that either benign or malignant, and you only know that by looking at the cells. So the question is how can we tease these three or four lesions out? So the literature is now quite ubiquitous, with a lot of things on immunohistochemistry and on cytogenetics. So I've highlighted, and I presented cases like this at our pathology meeting a few years ago. This was a set of cases that I thought was interesting. So when you look at actinic cell carcinomas, there's actually one immunohistochemical stain that will help you, and that's DOG1. And with secretory carcinomas, if you don't have the genetics, because we know there are N-trick mutations associated with secretory carcinomas, but almost uniformly, these lesions will be positive for mammoglobin and S100. And a strong mammoglobin positivity should lead you, even without genetics. And I've talked to Dr. Sitala about this. I've sent him cases. He says, if you have a strong mammoglobin positivity and everything else is negative, you can presumptively say this is going to behave like a secretory carcinoma. It's important because these tend to have a little higher rate of high-grade transformation. The easiest way to tease out a mucoepidermoid carcinoma is in secretory carcinomas. If you do a PAS diastase, usually it's the secretory product that will highlight and the cells will not. In a mucoepidermoid carcinoma, if you try to highlight the intracellular mucin, it's going to be the cells that highlight, and they will also be negative for DOG1. So a few immunohistochemical stains like DOG1, S100, and PAS diastase, and interestingly enough, strong overall positivity in most of the cells will help you tease out a mucoepidermoid carcinoma, as opposed to this combination of P63 and P40 that lends itself more to these polymorphous adenocarcinomas. And we're fortunate now to know that there are two genetic tests we can do on these. If we have an N-trick mutation, that will lead us to a secretory carcinoma diagnosis. And if we have the CRTC mutations, those will lead us to a mucoepidermoid carcinoma. And so what I attempted to do is put all of this complicated stuff. Somebody said this looks like an old record. Like, so, you know, here's the record. And so what I tried to tell my residents is that in small biopsies or fragmented specimens, we may have trouble teasing out some of these myoepithelial or biphasic tumors, right? Because all of these tumors can have mucinous components. All these tumors can have an epithelial or a myoepithelial component. And the same is true for basaloid tumors. On a needle aspiration or on a small biopsy or fragmented specimens where I can't see the whole thing. Like in these cases, I showed you the interface between the tumor and the encapsulation and the normal gland. If you have a small specimen, all I can tell you is that it's a basaloid carcinoma. And then all these other sort of, quote, low grade to high grade carcinomas are going to include all the other tumors that may all have some kind of biphasic appearance or may have a secretory appearance. And then what we can do is we can tease out through the biphasic tumors. We know that adenoid cystic carcinomas have some genetic components with MYB mutations. We know that the whole mixed tumors and carcinoma X will have plague tumors. And then obviously when they start picking up MDM and TP53 mutations, we know that those mixed tumors are probably not going to behave like mixed tumors. They're going to behave like carcinoma X mixed tumors. And then we know that some of the higher grade carcinomas will pick up those and other mutations, TP53, androgen receptor copy gains. So what I tried to do here is I tried to encapsulate all these sort of low grade carcinomas and put all the genetics there, because if you go around the wheel, these lesions can overlap in their appearance. The same is true for a lot of the potentially higher grade tumors. All of these tumors that have clear cell components, secretory components. And I think the way we tease these out now are through the immunohistochemical stains in the blue boxes. So I've already mentioned that P63 can be very, very useful for a mucoepidermoid carcinoma, DOG1 for actinic. We're knowing now that mammoglobin and GATA3 can be very useful along with mutational analysis, and we can do this with next generation sequencing now for NTRK mutations. We know that clear cell carcinomas now have Ewing sarcoma translocations. We know that renal cell-like carcinomas may actually show features of RCC immunohistochemistry. And we know these cribriform and ductal carcinomas are now turning out to have some specific genetic characteristics to them as well. And so what I did is I asked Raja Sitala if I could use his table. He's out of University of Pittsburgh. And so he did a nice job just a couple of years ago, about four or 5 years ago, and put together all of the mutational analyses that they had discovered at the time. This table is going to get larger over time, but I think that helps us. So that's kind of my run through salivary cancers.